Welcome to our video on qualitative platelet disorders. Let's begin. In this lecture, we will discuss the qualitative platelet dysfunctions including Bernard-Solier syndrome, Glanzmann Thrombasthenia, and Wieland-Willebrand disease. For each of these conditions, we'll talk about the pathophysiology, clinical presentation, diagnosis, and management. Let's start with Bernard-Solier disease. Bernard-Solier disease is an autosomal recessive disorder caused by a deficiency of GP1B. Let's recall that this glycoprotein is necessary for platelet adhesion to von Willebrand factor. Deficiency of GP1B causes decreased platelet adhesion and increased bleeding tendency. Let's revisit this illustration that we discussed earlier in the lecture. As we already mentioned on the previous slide, Bernard-Solier disease is due to GP1B deficiency. Now we can see how this deficiency will impair platelet adhesion to von Willebrand factor. Symptoms in patients with Bernard-Solier disease start in childhood or early adolescence because it is a genetic condition. The clinical presentation of Bernard-Solier disease is no different than that of any other platelet disorder. These patients have easy bruising and petechia or purpura on their skin. In addition to subcutaneous bleeding, they might also have epistaxis, GI bleeding, menorrhagia, or hematuria. Let's move to the diagnosis of Bernard-Solier disease. A complete blood count may reveal thrombocytopenia because GP1B plays an important role in platelet formation in the bone marrow. A peripheral smear will show giant platelets because GP1B deficiency does not allow platelets to mature in the bone marrow. Bleeding time will be increased because this disorder interferes with primary hemostasis. On the other hand, prothrombin time and partial thromboplastin time will be normal because Bernard-Solier disease does not interfere with the coagulation cascade. Finally, Bernard-Solier disease is characterized by an abnormal ristocetin test that is not correct with mixing studies. Let's discuss this concept on the next slide. Ristocetin normally induces binding of von Willebrand factor to GP1B. In other words, ristocetin causes platelet adhesion. Therefore, if we don't have GP1B, then ristocetin test will be abnormal. If we add the donor plasma to the patient's blood, this will be called a mixing study. The donor plasma contains von Willebrand factor, but it does not contain platelets and GP1B. Therefore, ristocetin tests will not correct with mixing studies. This is an absolute contrast to von Willebrand disease. If the patient is deficient in von Willebrand factor, then adding the donor plasma with this factor will correct the ristocetin test results. This is a blood smear image showing giant platelets. Please take a look at these large platelets, characteristic of Bernard-Solier disease. Let's move on to the management of Bernard-Solier disease. These patients should receive antifibrinolytic agents such as aminocaproic acid or tranexamic acid before procedures with a high risk of bleeding. These medications inhibit the breakdown of clots, minimizing the patient's risk for bleeding. Additionally, women with Bernard-Solier disease may need oral contraceptive pills for heavy menstrual bleeding. Otherwise, treatment is supportive. Let's move on to Glanzmann Thrombasthenia. Glanzmann Thrombasthenia is an autosomal recessive disorder caused by a deficiency of GP2B3A. GP2B3A is necessary for platelets to aggregate and attach to one another. Therefore, this condition causes decreased platelet aggregation and an increased bleeding tendency. Let's revisit this illustration again. As we already mentioned on the previous slide, Glanzmann Thrombasthenia is due to GP2B3A deficiency. Now, one can see how this deficiency will impair platelet aggregation. The clinical presentation of Glanzmann Thrombasthenia is identical to that of Bernard-Solier disease. Patients experience skin and mucosal bleeding since childhood. Let's discuss the diagnosis of Glanzmann Thrombasthenia. Complete blood count will show a normal platelet count because this condition is purely a qualitative platelet dysfunction. A peripheral smear will show no platelet clumping because platelets cannot attach to one another. Bleeding time will be increased because this disorder interferes with primary hemostasis. On the other hand, the prothrombin time and the partial thromboplastin time will be normal because Glanzmann Thrombasthenia does not interfere with the coagulation cascade. Glanzmann Thrombasthenia is characterized by no platelet aggregation with the addition of adenosine diphosphate, ADP. ADP normally upregulates GP2B3A receptor on platelet surface. Since these patients are deficient in GP2B3A, they will not have enhanced platelet aggregation with the addition of ADP. Let's revisit this illustration again. As we already mentioned in the previous slide, ADP upregulates GP2B3A on the platelet surface. Glanzmann thrombasthenia is due to GP2B3A deficiency. Therefore, platelet aggregation will not happen with the addition of ADP in patients with Glanzmann thrombasthenia. Moving on, let's talk about the management of Glanzmann thrombasthenia. Platelet transfusion is the mainstay of treatment of Glanzmann thrombasthenia. Recombinant factor 7A has been recently approved for refractory cases before procedures with high risk of bleeding. While the mechanism is not entirely understood, factor 7A seemed to induce a procoagulant effect. Additionally, women with Glanzmann thrombasthenia may need oral contraceptive pills for heavy menstrual bleeding. Otherwise, treatment is supported. Let's move on to von Willebrand disease. Here is our overview slide. Von Willebrand disease is an autosomal dominant disorder. It is the most common inherited bleeding disorder. The most common cause of von Willebrand disease is deficient von Willebrand factor. Let's recall that von Willebrand factor normally binds to GP1B, leading to platelet adhesion. Therefore, the patients with this condition have decreased platelet adhesion and increased bleeding tendency. Here we see the illustration that we have revisited several times. As we already mentioned on the previous slide, von Willebrand disease is due to von Willebrand factor deficiency. Now we can see how this deficiency will impair platelet adhesion. The clinical presentation of von Willebrand disease is no different than that of any other platelet disorder. Patients experience skin and mucosal bleeding since childhood. Let's talk about the diagnosis of von Willebrand disease. A complete blood count will show a normal platelet count. Bleeding time will be increased because von Willebrand factor is necessary in primary hemostasis. Prothrombin time is normal because von Willebrand factor does not influence the extrinsic or common coagulation pathways. However, PTT may be slightly elevated. The underlying cause of this finding is mild factor VIII deficiency. Normally, von Willebrand factor carries and protects factor VIII in plasma. Therefore, von Willebrand factor deficiency will cause a slight decline in factor VIII levels. Von Willebrand disease is also characterized by an abnormal ristocetin test. However, the ristocetin test results correct with mixing studies due to the mechanism that we explained before. This is in contrast to Bernard-Solier disease, in which ristocetin test results do not correct with mixing studies. Additionally, platelet aggregation will happen with the addition of adenosine diphosphate. As we already mentioned, ADP upregulates GP2B3A receptors. Glanzmann thrombasthenia, on the other hand, will not reveal platelet aggregation with the addition of ADP, because it is characterized by GP2B3A deficiency. Let's revisit this illustration briefly. Now, in case of von Willebrand disease, we do not have von Willebrand factor. If we add the donor plasma to the patient's blood, this will be called a mixing study. The donor plasma contains von Willebrand factor. Therefore, the ristocetin test will correct with mixing studies in case of von Willebrand disease. This is because mixing of the recipient and donor plasma will replete von Willebrand factor in the donor plasma. And finally, let's talk about management. Mild von Willebrand disease is treated with desmopressin, which is a vasopressin analog. Desmopressin releases von Willebrand factor and factor VIII from the endothelial cells, alleviating symptoms of the condition. Moderate and severe von Willebrand disease, on the other hand, are treated with von Willebrand factor replacement. A 15-year-old girl comes to the physician due to heavy menstrual bleeding. She has had multiple episodes of nosebleeds since childhood. Her mother, brother, and maternal aunt have similar complaints. The physician suspects genetic bleeding disorder. Diagnostic tests confirm the suspected condition, and the physician prescribes desmopressin to the patient. How will this medication likely benefit the patient? This patient has heavy menstrual bleeding and multiple episodes of nosebleeds. Considering that multiple relatives are similarly affected, a genetic bleeding disorder is suspected. The most common inherited bleeding disorder is von Willebrand disease, which is most likely in this patient. The physician prescribes desmopressin. Desmopressin, a vasopressin analog, releases von Willebrand factor and factor VIII from the endothelial cells, facilitating clotting in patients with von Willebrand disease. Here we have the algorithm of how to approach the patient with suspected platelet disorder. First, we need to check the platelet count. If the platelet count is less than 150,000, then the patient has thrombocytopenia. If the platelet count is normal, then we are dealing with qualitative platelet dysfunction. Let's first discuss the left side of the algorithm. If the patient with thrombocytopenia has started heparin within the last 2 weeks and the platelets have dropped more than 50% of the baseline, then he or she has heparin-induced thrombocytopenia. If the patient is not on heparin, then we should obtain a complete blood count and basic metabolic panel to check for hemolytic anemia. If hemolytic anemia is present with neurologic symptoms, the most likely diagnosis is thrombotic thrombocytopenic purpura. If there are no or mild neurologic symptoms, then we are most likely dealing with hemolytic uremic syndrome. If there is no hemolytic anemia, but the patient has signs of infection, we should think about conditions like Rocky Mountain spotted fever, ehrlichiosis, Lyme disease, cytomegalovirus, and so on. If there is no infection, then the most likely diagnosis is immune thrombocytopenic purpura. Let's move to the right side of this algorithm where we have qualitative platelet disorders with normal platelet count. The first thing we want to know is whether the patient has a family history of bleeding tendency. If there is no family history, then we should measure blood urea nitrogen and creatinine. If both these markers are high, the patient likely has chronic kidney disease with uremic coagulopathy. If these renal markers are normal, then we should think about medication-induced platelet dysfunction. If the patient has a family history of bleeding tendency, then we want to check if there are giant platelets on peripheral smear. The presence of giant platelets suggests the diagnosis of Bernard-Solier syndrome. If there are no giant platelets, then we should obtain a PT, PTT, von Willebrand factor levels, platelet aggregation assay, and factor VIII levels. If platelets aggregate with the addition of adenosine diphosphate, then we are dealing with von Willebrand disease. If there is no platelet aggregation upon ADP addition, then the most likely diagnosis is Glanzmann Thrombasthenia. An 8-year-old boy is brought to the physician by his mother due to recurrent progressively worsening nosebleeds. A thorough past medical history reveals that his mother and father are cousins. The physical exam reveals multiple petechia and purpura diffusely on the skin. Complete blood count is normal. Bleeding time is 10 minutes. PT time is 14 seconds. And PTT is 35 seconds. The patient has an abnormal ristocetin cofactor assay, which does not correct with the addition of plasma. Which of the following is the most likely diagnosis in this patient? A. Bernard-Solier disease. B. Von Willebrand disease. C. Glanzmann Thrombasthenia. Or D. Hemophilia A. The boy presents with recurrent, progressively worsening nosebleeds. The physical exam reveals multiple petechia and purpura diffusely on the skin. Mucosal and skin bleeding suggest a platelet disorder. The patient is an offspring of the consanguineous marriage evidenced by his mother and father being cousins. Consanguineous marriages increase the risk for autosomal recessive disorders. Therefore, the patient likely has an autosomal recessive platelet disorder. Platelet disorder is further suggested by the bleeding time of 10 minutes, which is prolonged. The patient has an abnormal ristocetin cofactor assay, which does not correct with the addition of plasma. Abnormal ristocetin cofactor assay is seen in both Bernard-Solier disease and von Willebrand disease. However, abnormal ristocetin cofactor assay does not correct with the addition of plasma in patients with Bernard-Solier disease. This is because the patients with Bernard-Solier disease have an autosomal recessive deficiency of GP1b glycoprotein on the platelet surface. This glycoprotein is absent in the plasma, so the correct answer is option A. Here's a slide reminding us of the diagnostic tests for Bernard-Solier disease. Let's discuss why the other options are incorrect. Option B, von Willebrand disease, is incorrect because although it's associated with an abnormal ristocetin cofactor assay, the ristocetin test corrects with the addition of plasma. Additionally, von Willebrand disease is typically associated with prolonged partial thromboplastin time due to mild concomitant factor VIII deficiency. Option C, Glanzmann Thrombasthenia, is incorrect because although it's characterized by prolonged bleeding time, it's not associated with the abnormal ristocetin cofactor assay. Finally, option D, hemophilia A, is incorrect because it's associated with prolonged partial thromboplastin time. And that concludes our lecture on qualitative platelet disorders.